Good afternoon, everybody. My name is Sharon Rounds, and I'm the principal investigator for Advanced Rhode Island CTR, which is a uh, program funded by the NIH to enhance research infrastructure in the state of Rhode Island. Every month, we have a clinical and translational research seminar series, and this month, we're very pleased to have two speakers who have been, both of whom have been awarded research grants from Advanced CTR to tell us about their work. We're really looking forward to hearing about it. The first speaker is Julia Shinnick. Julia is an assistant professor of obstetrics and gynecology at Women and Infants Hospital and obviously at Brown. And she is a urogynecologist who is an expert on urinary tract infections in women and I guess men also. And she'll be talking to us today about intravesical installation of gentamicin for prevention of recurrent UTIs. So thank you, Julia, and take it away.
Thank you so much for that kind introduction and for giving me this opportunity to talk about my pilot project work, intravesical installation of gentamicin for prevention of recurrent UTI. This project was funded through the Pilot Projects Program in Cycle 9, and we have no other financial disclosures. We'll start by talking about the community impact and importance of UTIs in Rhode Island, and then I'll go into our trial rationale and design and our pilot trial clinical results. We're still working on our microbiome analysis, and I'll talk about our expected microbiome outcomes as well. So starting off with, what is a urinary tract infection? There are many things that can cause bladder discomfort and pain, but a UTI is typically characterized by frequency, urgency, and burden with urination. In this setting of inflammatory markers on urine studies, such as white blood cells and leukocyte esterase, and a urine culture that's positive for a uropathogen. In Rhode Island, UTIs are actually a leading cause of preventable emergency department visits and the second most common cause of hospital admission amongst our population that's older than age 65. UTIs alone account for over 1,200 hospitalizations each year in Rhode Island. And this is proportionate with the national burden that UTIs pose to the United States. They impact millions of people each year, and they are much more common in women, particularly as women get older. UTIs pose a tremendous burden to our healthcare system in terms of the number of clinic calls and outpatient visits that they lead to, hospitalizations, antibiotic use to treat UTIs, and misuse, misdiagnoses of things that aren't UTIs that contribute to infections elsewhere in the body and resistance. When people get frequent UTIs, they can be diagnosed with recurrent UTIs, which is defined as greater than or equal to 2 urinary tract infections in 6 months, or greater than or equal to 3 urinary tract infections in 1 year. Repeated urinary tract infections are associated with antimicrobial resistance, both within uropathogens in the patient and in our communities. Antibiotic side effects, rashes, nausea, other site infections like C. diff, and adverse downstream health effects in both the patient and our community members. When patients have frequent UTIs, One approach is to give them systemic preventative antibiotics, hoping that frequent small doses of antibiotics will keep uropathogens at bay and prevent these large uncomfortable episodes that require large doses of less specific antibiotics. Common preventative antibiotic options are trimethoprim, nitrofurantoin, cephalexin, and fosfomycin. And these are typically given at low doses every 1 to 3 to 7 days, depending on the antibiotic. Antibiotics for both the acute treatment of UTIs and prevention of UTIs are typically given orally and associated with side effects, including rashes, dizziness, nausea, diarrhea, yeast infections in women. And these are all very uncomfortable experiences for patients and one of the main limiters of prophylactic antibiotic use. People have done studies on patients with recurrent UTIs and asked them what is really important to you in managing this condition and where is there the most room to make progress in terms of patient-centered care. Patients have reported that burden imposed by UTIs and frequent interactions with the healthcare system really weigh on them, and that they're interested in education and preventative strategies to reduce antibiotic intake, largely due to concerns of antimicrobial resistance. In other fields, installation of gentamicin directly into the bladder has shown to be effective in preventing UTIs, though these studies have largely been limited to pediatric and neurogenic bladder populations. These studies have not really consistently included postmenopausal patients who didn't have neurogenic bladder, but given that postmenopausal patients have such a high prevalence of recurrent UTIs, and they have a very unique microbial environment after menopause, it could be very helpful to study intravesical gentamicin in postmenopausal patients. So we know that our patients have this unique microbiome aspect. They're suffering from recurrent UTIs, and there is this therapy that is helpful in other populations, but it's never been looked at in postmenopausal women. But we don't know if postmenopausal women are open to this treatment. So my pilot project's primary aim was to determine the feasibility of recruitment and retention for a fully powered trial comparing systemic nitrofurantoin, so that's oral macrobid nightly, our current standard of care, to local gentamicin instilled into the bladder. So comparing the gentamicin bladder installations to the current standard of care of oral macrobid. Our primary aim was feasibility, but our secondary aims were clinically and microbiologically oriented. So for our clinical aims, we were examining culture-proven UTIs and patient-reported outcome measures. And in terms of our microbiome aims, we plan to look at alpha and beta diversity, antimicrobial resistance genes, and microbiome correlates with clinical outcomes. We hypothesized that patients would agree to be randomized to intravesical gentamicin versus oral nitrofurantoin. And we also hypothesized that intravesical gentamicin prophylaxis would be associated with similar UTI incidence at 12 weeks, better patient-reported outcomes, and favorable urobiome shifts. But that leads to the question, will patients join a study that involves local administration of antibiotics? So they're still getting antibiotics, but now they're getting them through a catheter, which can be off-putting for many lay people and even physicians alike. So to help answer this question, our kind of first feasibility step, we help community engagement studios to kind of meet with patients and community members and explore more about their needs and preferences for a study looking at recurrent UTIs. So we held 4 community engagement studios. 2 were with English-speaking community members, and 2 were with Spanish-speaking community members. And during these studios, we talked about recurrent UTIs as a problem in general, about their needs as people who suffer from or support those who suffer from recurrent UTIs, and what would really be an acceptable patient-centered trial in their eyes. The community members articulated that they wanted to minimize clinic visits. So while in some of the earlier gentamicin studies, gentamicin was administered anytime from every night to once a week, our community members were like, I'm not open to coming into the office more than once a week. And many actually asked if they could do it nightly, but at home. We had also initially considered a 6-month study duration, but our community members emphasized that they know if a treatment is working much, much sooner than that. And they felt that within 6 weeks, they could tell if they were receiving appropriate and sufficient treatment for their recurrent UTIs. Overall, we learned that our community members were really, really eager to learn more about the urobiome. They were excited to learn about the good and bad bacteria in their bladder, and they weren't concerned about studies that were looking at that. And they were very comfortable providing urine samples. There is a DNA component, it's bacterial DNA that we're examining, and community members appeared very comfortable with that. So with the input from our community members, we designed and launched this pilot randomized trial comparing systemic nitrofurantoin to local gentamicin. And we collected urine samples at baseline, 6 weeks of treatment, and 6 weeks post-treatment to evaluate post-treatment effect. We included postmenopausal patients starting antibiotic prophylaxis for recurrent UTIs who had had at least 2 UTIs within the last 6 months. We excluded people who had a history of kidney infections or pyelonephritis, urinary retention, a structurally abnormal lower urinary tract, or a history of complicated UTIs. We have a schematic here that shows we would approach our population in clinic. If they consented, we would talk to them about the study. If they consented to participate, they would complete baseline questionnaires and then be randomized either to the treatment on the left, which is instillation of antibiotics directly into the bladder, or oral nightly systemic prophylaxis, which is the current standard of care. The participants received treatment for 6 weeks, and then they stopped treatment and were observed for an additional 6 weeks. At the end of that time, they completed questionnaires again. So baseline, 6 weeks, and 12 weeks. In terms of our primary clinical outcome, we examined our number of culture-proven UTIs and various patient-reported outcome measures that have been validated in recurrent UTI populations. These were largely UTI symptom scales and life impact questionnaires, and also health-related quality of life measures. The literature is pretty immense, demonstrating the associations between recurrent UTIs, anxiety, and depression. So we also included the General Anxiety Disorder 7 and Patient Health Questionnaire 9. From a microbiome standpoint, we collected urine samples at baseline after the 6 weeks of treatment, and then the 6 weeks later when they had been off of treatment for 6 weeks, so 12 weeks from baseline. In terms of our analysis, for our primary aim of determining feasibility of a larger trial, we were hoping to find a ratio of eligible patients that were screened to enrolled greater than or equal to 1 to 5, so 20% of eligible patients agreeing to do the study, and have our proportion with participants with 12-week outcome data be greater than or equal to 80%. In terms of our clinical secondary aim, we plan to use a generalized linear Poisson model comparing intravesical to oral therapy with alpha set at 0.05 and beta set at 0.8 and a standard deviation of 1.5 and an equivalence limit of 0.5. With these parameters, a final fully powered trial would need to include approximately 124 patients. And in this pilot trial, we were hoping to assess feasibility of randomization, study estimates, and microbiome analysis planning, and we were aiming for about 10 participants in each arm. In terms of analyzing our patient-reported outcome measures, we are dichotomizing them according to change less than or greater than the minimum clinically important difference, using chi-square or Fisher exact tests to compare treatments, and repeated measures ANOVA and regression models to evaluate associations between the treatment groups and clinical and demographic factors. For our microbiome aim, we're using raw shotgun metagenomic sequencing, allocating DNA reads to bacterial taxa, and reporting alpha and beta diversity. We'll also be making comparisons between lactobacillus species and common uropathogens, including E. coli, Klebsiella, Proteus, and Pseudomonas. We will examine bacterial gene pathways, virulence genes, and antimicrobial resistance genes, and compare our clinical parameters to examine for microbiome associations. In terms of our outcomes, we screened over 300 patients in approximately 4 months. 83 patients were eligible, and 28 of the 83 eligible patients were not able to be approached for one reason or another. Of the patients who were approached, there were 55, and 62% of them declined, but 38% of approached participants ended up enrolling. So that's about 1 in 3 patients who we approached agreed to participate. In terms of our outcome data, we had 21 participants enroll and 1 withdrew prior to 6-week follow-up. 20 participants had complete 12-week outcome data, which is 95% of our enrolled patients having complete outcome data. This is our population here. Consistent with the population at Urogyne at Women and Infants, our mean age was 68. It was predominantly white, and half of our participants were retired. There are very relevant differences between the groups despite randomization. In particular, vaginal estrogen use is associated with a 60% decrease in UTI incidence, and only 22% of the gentamicin arm was using vaginal estrogen, while 64% of the nitrofurantoin arm was. Number of UTIs in the preceding year is also the strongest and most reliable predictor of future UTIs, and there were a greater number of UTIs in the prior year amongst the gentamicin arm. Cranberry use is associated with an approximately 30% decrease in UTI incidence, and cranberry use was also less common in the gentamicin group. And BMI was higher in the gentamicin group. BMI is associated with a 4-fold increase in UTI risk as it increases. In terms of our compliance outcomes, 1 participant in the gentamicin arm did request transition to the nitrofurantoin arm, secondary to a mobility issue that arose during the study period. She had an unrelated fall on a weekend in between treatments and said that because of her mobility limitations, she either wanted to be able to do the installations herself at home or transition to the other arm, and unfortunately we cannot offer a home option for this small study. 2 participants in the nitrofurantoin arm discontinued treatment secondary to side effects from the medication. Of the 9 participants randomized to gentamicin, 1 participant missed 3 installation visits related to concerns regarding ice. Their transport, their ride to the visits had a lot of concerns related to increased activity. 1 participant also missed 1 installation due to a summer scheduling conflict. They were having their installations administered over the summer, and they had had a vacation and were not able to attend the week that they were out of town. 44 of the 48 weekly visits were attended within window. In terms of our clinical outcome of UTI incidence, 55 participants had UTIs in the gentamicin group, while 27 participants had UTIs in the nitrofurantoin group. Amongst those who had UTIs in general, there were 1.4 UTIs per person in the gentamicin group and 1.67 UTIs per person in the nitrofurantoin group. Well, that doesn't look particularly promising on the surface. If we remember the differences between the groups at baseline and the magnitude of the risk differences before treatment, it is less impressive. When we adjusted for BMI and vaginal estrogen alone, our adjusted incidence rate ratio was 1.14, which actually showed that nitrofurantoin, those exposed to nitrofurantoin were more likely to have a UTI when controlled for those other variables. We also noted changes in anxiety scores over the course of the treatment, though in the gentamicin group, anxiety was higher at baseline. And we have expected results for a microbiome analysis. We expect that the treatment of gentamicin will decrease relative proportions of E. coli, Klebsiella, Proteus, and Pseudomonas while preserving those very important lactobacillus species, which help decrease the pH in the vagina, which decreases uropathogen colonization. We hypothesize that participants who have decreases in uropathogenic bacteria will have fewer breakthrough UTIs and greater improvements in patient-reported outcomes, and that reduction of pathogenic species will be associated with a lower relative abundance of virulence genes and antimicrobial resistance genes. Here are my references. And I wanted to thank my primary mentor, Dr. Vivian Song, and my urogynecology research team. The incredible Belinkie lab at Brown is performing our microbiome analysis, and they have been tremendous collaborators. Rochelle Rosen and Christopher Schmid were incredible in designing this study and making it into what it was able to become. And I am always so thankful for Hilda and Tammy and our Community Engagement Corp. I spent so much time with and have learned an incredible amount from with their community engagement experience and studio experience. Has really been so formative in my research career already in the Women and Infants Division of Research. I'm happy to take any questions.
Fantastic. Thank you so much. That was great. Virtual applause. I'll start off. How much systemic absorption is there of the intravesical gentamicin?
Yeah, very, very little. Most of the studies have been done in the pediatric and the neurogenic bladder populations, and it's typically detectable, but nowhere near therapeutic.
And what about AKI or hearing loss with prolonged intravesical gentamicin?
So they have not found those side effects in the populations where they've been evaluating serum levels or longer term use. I'm unfamiliar with data beyond 2 years, but in the safety data we have across various studies, those have not been associated with intravesical use.
With intravesical. And I guess another question I would have is, what's the next step?
Yeah, I think the next step would be, of course, completing our microbiome analysis. I think the R that we will write will depend on kind of how things are looking from that standpoint. But I think this, of course, there's nothing definitive from the study. It is so small. But I think what we have is that it's promising and it's feasible.
That's great. Fantastic. Well, congratulations. I think that was just an extraordinarily well-designed small clinical trial. It should be a model, I think, for everything from the community engagement studio to sophisticated microbiome analysis. That's really great. I just looking in the chat here, I don't see any other questions right now. So, and again, congratulations. And I presume that you will be submitting this for publication once you get the microbiome analyses.
Of course.
Great. Well, great work. Thank you, Julia. We'll move on to our next speaker. Let's see. Great. So our next speaker is Dr. Fabian Fischer. He's an assistant professor of biomedical and pharmaceutical sciences at the University of Rhode Island. I believe that you joined the faculty at the University of Rhode Island, I guess last year, fairly recently. Welcome to Rhode Island. Um, he is going to be talking about his research on precision environmental health of emergent contaminants, risk stratification, and intervention. So take it away, and thank you for coming.
Yes, thanks, Sharon, for the introduction, and thank you for giving me the opportunity to talk in this panel. It's actually almost 3 years ago that I joined URI now, and we have made a lot of progress, I think, in working on the topic of precision environmental health of emerging contaminants. So I will not necessarily talk about drugs or medication today, but really about the chemicals that we find in the environment and how they affect our everyday life. Just getting rid of some of the Zoom stuff here. Yeah, and just to take a step back and tell you guys why I'm so passionate about understanding the health effects that environmental chemicals pose to us. If you see here, these are the planetary boundaries. I think everyone is familiar with those, and environmental chemicals or chemicals, manufactured chemicals in the environment are part of the novel entities, and we already exceeded the safe operating space by a lot for those. There's a global release of already proven to be toxic chemicals of 310 kg per second, and that's kind of scary because these are already proven to be toxic. We also know, and these are estimated values, that chemicals contribute to around 2 million deaths per year and 53 million disability-adjusted life years. That's data from 2019. So there's both a loss of life and also a loss of quality of life associated with a lot of chemicals out there. Back in the days, we had quite a low number of chemicals that have been excessively used, like DDT, which is definitely not good for you. This has been shown for multiple organisms and ecosystems. And nowadays, we're exceeding the number of chemicals registered in the CAS database by over 200 million. And it's not only the number of chemicals that increase, but also the complexity of chemicals. And there are so many chemicals that have to be screened for how they distribute in the environment, how they reach our bodies, and what they do to our health, that we need alternative methods and cannot rely on just animal tests all the time. There's also a disproportional threat to children. We know that 54% of the disability-adjusted life years occur in those under 15. And we also know that 1 in 6 children now face some sort of neurodevelopmental abnormality. And all of those are linked to chemical exposures like pesticides or metals. There's also a disproportionate chemical burden in certain countries because we relocated manufacturing of a lot of chemicals and industrial productions to different countries. We have, for example, PFAS concentrations. PFAS are these forever chemicals that are all over the media, and I will talk about them a lot later in the talk. You find 13,000 nanogram per liters, for example, in India's Peria River. So this is this river here, and people mistake these bubbles for detergent, for soap, and they go into the river and clean themselves with highly toxic contaminated water. So there's a lot of stuff to digest here, but we really work on precision environmental health because we want to protect the most vulnerable, because they're either in a very vulnerable state of their life, like children or pregnant women. And this is essentially also what my advanced CTR project is about, and I will talk about this later. And we also want to protect those that are disproportionately exposed to those chemicals. And NIH has advanced and kind of defined precision environmental health, and I extracted 4 categories that I found particularly interesting and relevant to my work. The one is we have to figure out what are the dominant exposure routes, right? That's an easy one, but we also want to figure out what biomolecular and physicochemical mechanisms drive absorption, distribution, metabolism, and excretion. So I think a lot of you guys had pharmacokinetics in college, so you kind of know what ATME is. So I'm teaching pharmacokinetics as well. I'm very interested in kinetics in general, and we are trying to understand ATME of those environmental chemicals. And that's particularly important for identifying highly susceptible individuals, we need to understand how disease burden, malnutrition, obesity, climate stress, and other global health disparities affect how chemicals accumulate in your body and if they increase the risk for toxicity. And then obviously we do all of this because we want to come up with intervention and regulatory strategies to reduce harmful exposures and protect the most vulnerable. So how does it work? There's different puzzle pieces to it. We try to understand exposure sources. So most of us here on the call most likely get all of their chemical burden from drinking water, diet, or inhalation of volatile compounds, but then and also indoor and outdoor. But obviously, there's also high-risk populations like firefighters, medical personnel, military personnel that have particularly high chemical exposures of people working in agriculture when we talk about pesticides. So we're trying to understand those sources, and we also try to understand what, as an individual, makes you particularly susceptible for accumulation and health effects. So we know that, for example, certain medications, if you're taking certain medications that slow down your metabolism, you might accumulate toxic chemicals that you take up from the environment to a larger extent than someone else. Or you drink a lot, or you have a certain diet that affects how those chemicals are being absorbed in your gastrointestinal tract. And then there's intrinsic factors that can vary by age and sex and gender, or you have certain times in your life when you're pregnant where you're particularly susceptible, either you or your fetus is particularly susceptible, or there's a risk that you transfer your body burden to your born child during lactation, and especially the lactation part is exactly what I wanted to figure out in the advanced CTR, and I will come to this later. So the first part of the talk is really giving you an overview of what we're doing. The second part is giving you an overview of the tools that we have to understand all of these different mechanisms here. And the third is that I will show you 2 case studies, and one of them is our advanced CTR project. So we're trying to understand both the exposure sources and then the factors, either intrinsic and extrinsic, to do risk stratification. So we stratify people according to different categories and stratify their risk. Eventually, what we want to achieve is that I will know all of this information about someone, and I can provide a personalized risk score for this particular individual. We have lots of puzzle pieces that we use to do precision environmental health. So we obviously do a lot of mass spec to analyze those chemicals in different environmental media, but also in different tissues of humans that we extract for different compounds. We use a lot of in vitro bioanalytics to test for different pharmacokinetic endpoints and for those compounds. We use rodent studies to confirm, and we use a lot of modeling. So I'm more on the modeling side. I do a lot of computational modeling. So this is all a lot, so that's why I love collaborations. I'm very promiscuous when it comes to collaborations, so please reach out if you're interested in getting involved. I have lots of colleagues who work on all these different puzzle pieces, and they help me establishing these frameworks. So how does it look like if you think about a precision environmental health study recipe? If we have a compound, for example, or a compound class like PFAS, we do those in vitro bioanalytical assays with cell lines, and they test on a specific isolated mechanism. For example, tissue binding. We are testing for different membrane transporters that help or not help transporting the chemical inside your body or out of your body. We're also looking at effects, metabolism, and permeability, for example. So we generate a lot of pharmacokinetic data that we throw into a toxicokinetic model. So that's the computational part. And that toxicokinetic model can then predict what your steady state plasma concentration would be, your half-life, tissue concentrations, so concentrations at the target site, for example. If you think about a neurotoxin, what could the concentration in the brain be after 20 years of exposure, for example. And then obviously we use a combination of rodent studies and human exposure data to evaluate our model, if our model is doing right and or is precisely predicting how the compound is distributing in vivo. And we also do model refinement if we observe that, well, what our model is predicting is completely off the reality, and we have to redefine the model for additional processes. I talked about PFAS already, but to give you a little bit of introduction, PFAS are per- and polyfluorinated alkyl substances, and they are now pretty much virtually present in all living organisms. And everyone here on the call, if you give me your blood, I will promise you we will find detectable levels of PFAS in your blood. And those compounds are linked to multiple adverse health effects, including immune dysfunction, liver and cardiovascular disease. And we also know that elimination half-lives of PFAS are very variable across populations and between individuals, and they somehow correlate with how free the compound is in your blood serum. So you can see this here, these are different PFAS, and the more they are bound, so the lower this unbound fraction is, the higher the elimination half-life is. So the longer it takes your body to get rid of these compounds. And one of the questions that we had when we started working on precision environmental health of PFAS is, well, could differences in serum proteins that are associated with diseases or genetics and other covariates contribute to inter-individual variability in how strongly your body holds on to these compounds and how slowly they can be processed, right? And so PFAS, what really makes them special, unfortunately, is that they have elimination half-lives of up to years, whereas for most drugs, we see elimination half-lives of hours or days. So now I'm talking a little about the tools that we have in the lab. And if you think you want to use some of those tools for pharmacokinetic assessment of some of your compounds, please just reach out and we are happy to help you measuring certain things. For example, the binding of certain compounds in blood or different tissues. So what we use here is a C18 fiber-based microextraction method, where you basically add the biological material to this flask here, and you have a C18 fiber that accumulates PFAS and other compounds in their polymer. And basically from the difference in the fiber concentration in presence and absence of the biological material, for example, human serum albumin, that's the data shown here, you can calculate how much the compound binds to albumin or serum or tissue or whatever you want to measure. The good thing about this indirect method is that you don't have to extract the biomatrix yourself. Everyone here on the call who does mass spec knows that extracting chemicals from some sort of biomatrix like liver tissue is extremely ugly and can lead to high background effects. So we also use similar methods to measure the fraction unbound of different PFAS here, again, in human and rodent tissues. And both of these methods are published. We also have in vitro cell assays to measure toxicokinetics. So these are transwell assays. What you basically do is you have a genetically modified cell line that either lacks transporters completely. So this is here the membrane transporter, organic anion transporter, for example. It's a renal efflux transporter. So we have one cell line that lacks these transporters completely, and then we have a genetically modified cell, the same cell construct that overexpresses a certain transporter. Then we dose the chemicals to the apical side of this transwell assay, and we measure over time how much compound is distributed to the other side. And this gives you the permeability. Here you see some permeabilities for PFAS and also the uptake ratios for certain human organic anion transporters. You have to integrate, well, our goal is to really integrate, and like I said before, integrate these in vitro data into a human toxicokinetic model. What you have to do is you have to upscale those data appropriately. First, we have to define how the chemical distributes in the in vitro system, which can also be quite complex. We use a lot of in vitro distribution modeling to do so. And then you upscale to the actual organ, right? Because you basically grow a fraction of the tissue, just cells in your in vitro system, but eventually you want to upscale this to the whole organ level by using different scaling factors that account for the abundance of different enzymes in the assay as compared to the organ, and also the protein levels and eventually the organ weight. So now we have established a lot of data for PFAS, and we wanted to feed those data into the physiologically based toxicokinetic model as shown here. We have data on membrane permeability, different transporters, and we measured binding to serum albumin, serum globulins, bile, and all sorts of other human tissues. So this is how the model then looks like. Basically, this is an elimination model. So you kind of want to have your model as simple as possible. If you only think about elimination, it's actually okay to work with a gut, liver, kidney model, because those are the major compartments of the body that are responsible for absorption and elimination. And you can see here we have all of these data. And these data are being, and this is our in vitro data, are being fed into the models. So then what the model does is according to the binding to albumin, for example, fatty acid binding proteins, structural proteins, membrane lipids, etc., you have an unbound concentration or free concentration established in each of these compartments. And then the model calculates based on transport across these compartments based on either just passive permeability, so passive diffusion, or different transporters that uptake or efflux certain compounds in and out of your organs. The cool thing in these models is it's a kinetic model, so it runs in R, so it can give you then, again, like I said, predictions for half-life, plasma concentration, time profiles, etc. But we can also feed the physiology. So there's a lot of differences in physiology between individuals and within and across populations. So we have, for example, specified models for pediatric questions. We have a pregnancy model that we can use. We have a model for seniors where we account for the decline in kidney function over time. We also have different disease models. So you can feed them and then feed also these physiological parameters into the model and run a Monte Carlo simulation. The Monte Carlo simulation basically collects random sets of different data, both from what we measured in vitro and from human data and variability in all of these different physiological factors, and generates 10,000 different outcomes from which you can see, well, which are the individuals, what characteristics do individuals carry that are on the upper end of exposures, for example. So which physiological parameters are associated with more accumulation of toxic compounds in your body. And we obviously, with every model, we have to evaluate. So what we did is we set up a mouse physiologically based toxicokinetic model, and we compared the results of the model with mouse toxicokinetic data. So here, PFAS have been dosed orally to C57 mice, and then concentrations in the blood or plasma has been measured over time, and tissue concentration at the end. And you can see our model is doing really well in predicting those values. And again, this is a purely in vitro parameterized model. So we are not calibrating with in vivo data. We are calibrating with in vitro data for each of these isolated pharmacokinetic parameters, processes, and then we confirm that we are doing well. Obviously, I'm only showing you the nice agreement. So there's also compounds, short chain PFAS here, that the model is over predicting in terms of elimination. So that's the refinement part of what I'm talking about. We go back and we refine the model. We look for other transporters, for example, that may facilitate the elimination of these compounds. We also did it on the human level. So you can see here again, for most of these compounds, these are longer chain PFAS. The model predicts it relatively well as compared to measured human values. So these are liver plasma concentration ratios. But the shorter chain one, this is C6, is completely underpredicted in terms of accumulation in the liver. So then the question is, again, is there a certain transporter that we have to include in the model for this particular compound? So we go back into the lab and we measure more transporter data then. Or another very good example is these are predicted organ blood concentration ratios, and we are doing really well for kidney, liver, lung, and spleen in humans, but we completely over predict the accumulation in the brain. And that's why, because our current model is not accounting for the blood-brain barrier. So we started a project measuring blood-brain barrier permeability for PFAS. So now I want to show you two case studies. One is the albumin one that I talked about. So we used the C18 fiber method to measure binding to albumin, human serum albumin, and Y globulins. These are the two most abundant blood proteins in humans. You can see these are different PFAS. The cool thing is we can measure 54 PFAS with one experiment. So a lot of data coming out of this, which we can again use to do structural activity analysis. Don't want to go into details here, just want to show you that we have all of this data. Then we plugged it into our PBDK model. And this is a sensitivity analysis. So we are then basically perturbing one parameter 2 times. So we say, for example, we increase the albumin binding for a particular compound now by 2-fold, and we measure the change in outcome. So for example, if I increase the albumin binding of this particular compound here, PFHPA, then the elimination half-life increases by 44%, which makes sense because the more binding, the more the chemical is hold on into your body and the less is excreted over time. So one compound that stuck out was PFHXS, which had high sensitivity of albumin to both blood exposure and elimination half-lives, and it was not measured in rodents just yet. So together with my mentor, Angie Slitt, and her PhD student, Olga, we measured this compound in a wild-type mouse and then an albumin knockout mouse. So this mouse model completely lacks albumin genetically. And then they measured, again, elimination half-lives. And at the same time, we run our PBTK model for model evaluation with normal levels of albumin and 0 levels of albumin in this mice. And our model, again, does really well in explaining the difference. There's also effects on the tissue levels. So now, obviously, we want to go into humans. With humans, it's much more difficult because no one allows me to just dose them a high concentration of PFAS. Sorry, I think my microphone just got out. So no one allows me to dose a high concentration of PFAS IV. So I have to work with other human data. For example, here, the NHANES data that clearly shows that for albumin and globulins, you have quite large variability in both of these proteins. For example, lower values are associated with diabetes or fatty liver disease, and higher values of globulins are associated with cardiovascular disease. And with this data, we can predict, again, the unbound fraction in human serum. You should see this here. And again, not going into details, what I want to show you is you have lower levels of fraction unbound. So you may have delayed elimination for these people because they hold PFAS stronger in their blood. But you also have increased fraction unbound, which means increased elimination, but also PFAS are distributing more to other tissues where they can exert toxicity. Now, is it really matter in humans? So this is all like conceptually and theory, but does it really matter? So this is a proof of concept where we used our unbound and bound data to come up with a clearance value for baseline clearance. So this is just glomerular filtration. And we use the NHANES data to calibrate this model. And then in addition, we use an albumin clearance. And that albumin clearance basically accounts for how much bound PFAS is excreted from your body over time based on albuminuria. So especially in diabetes patients, you have high albumin leaching from the body. You basically pee out albumin because of damage in the glomerulus. So we wanted to account for that by adding this as a covariate in the statistical model that they are using at the University of Southern California. And you can see here, if you only do covariates, so these are predicted P4 levels against measured P4 levels in 80 individuals with chronic kidney disease. Covariates are basically when was the serum measured, because PFAS are declining over time, so the measurement time is very important. Or if they are female or male, what age those participants had, etc. And if you and the model doesn't really explain a lot. It's like 11% of the variability in P4 levels can be explained using just the covariates. And if you include the baseline clearance, which basically accounts for the unbound fraction, we end up at 19%. But if you account for what is additionally excreted through albuminuria, you start out of the sudden explain 56% of the variability in this cohort, which is, again, very exciting because we can prove in an EPI cohort that it really matters, that albumin is a very important carrier protein for PFAS, and depending on how much albumin you excrete into your urine, it will affect the levels of P4 building up in your bloodstream. Doesn't mean that PFAS are protective of, doesn't mean that chronic kidney disease is protective of PFAS health effects. Yes, you may accumulate less, but you already have impaired organ function. PFAS are kidney toxicants. So we are now going a step further and trying to evaluate the causality here. And then the case study 2, and now it gets interesting, and this is my last slide. I'm wrapping up after this. So this is my advanced CTR project, and I basically wrote this thinking, well, now that we see that it's very important for albumin, does it also matter? These concepts do matter for how much PFAS is accumulated in breast milk and how much PFAS is transferred from the mother to infants via breastfeeding. So we want to, in this project, and I'm very glad to have Liam, my PhD student, working on this, and Angie mentoring the whole thing. We are measuring interactions of PFAS with BCRP, which is the breast cancer resistance protein transporter. Usually it transports fatty acids from the mammary gland into the breast milk. But we also show now with data generated for this project that PFAS are strong substrates for this transporter. So not only PFAS may compete with which are very important nutrients, fatty acids for these transporters, but also people that may have a polymorphic BCRP, so that have higher activity, genetically high activity of this transporter, may transport disproportionately high levels of PFAS into the breast milk. So the idea here is really to show, well, maybe we need to do an intervention study here. The follow-up would really be that we work together with different epi experts, for example, Joe Brown, who we work with now on a more sophisticated toxicokinetic model for breast milk exposures. We also see, using our C18 fiber assay again, that especially short-chain PFAS have high propensity to distribute to breast milk. They're also substrates for this BCRP transporter. And not the good thing is, but again, there's new human data out showing that all of these compounds that we assessed here are actually showing up at high levels in human breast milk. So I think this pilot project was very important to generate the preclinical pharmacokinetic data. We are currently working on parameterizing the PBDK model, which is specifically designed to have the blood to breast milk transport process parameterized in large detail. And the next thing is really to go work with human data, preferentially human data that includes BCRP polymorphisms as risk factors. And with this, I love my lab. My students are great. My collaborators are great. Angie Slitt and her group are amazing. And I want to thank all of my other collaborators and also the funding sources, including obviously the Advanced CTR program. And thank you for your attention, and I'm happy to answer questions.
Thank you so much. Bravo. That's a very impressively complex sets of data analysis. So and also impressive facilities for looking into this at multiple different levels. It's really, I think it's really terrific that you're also working with human data. I guess that's in collaboration with the Brown School of Public Health. That's great.
Exactly.
So a bunch of questions come to my mind. A couple of these are somewhat naive, but I've become interested in microplastic contamination of the environment, and I'm wondering, do PFAS, are they bound to microplastics at all? And are microplastics a way of distributing this? Is it just foam, or are they present, adherent to other materials?
They are adherent to other materials, so they also can adhere to salts and sediments, for example. Everywhere where you have, for example, cation or anion exchange capacity in salts and sediments, they don't necessarily bind so much to polypropylene or polyethylene or polystyrene, so all of these plastics, which is good because we are using polypropylene vials in the lab to store PFAS. They actually bind more. They adhere more to glass because, again, you have more electrostatic interaction.
So it's a charge interaction.
Yeah, but there's definitely studies out there on other persistent organic pollutants. PFAS are highly ionogenic, so that's why they don't bind to neutral polymers so much, like plastics. But other POPs do, like PCBs or PHs. They bind very strongly to plastic. So then microplastics may be carriers for those into the environment, or also carriers when you ingest microplastics to certain organs in your body.
And a question comes up, how is unbound versus bound PFAS measured?
Yes, let me quickly go back to that slide. So we're using these C18 fiber-based SPME assays and also rapid equilibrium dialysis methods to measure partition coefficient. And the partition coefficient is nothing else than the concentration ratio between two phases. So if you have the human serum albumin water partition coefficient, that's your concentration in attached to the albumin, bound to the albumin, divided by the concentration of free PFAS in water, essentially. So if you wanted to calculate the unbound fraction, then the unbound fraction is then essentially the calculated from the partition coefficient using a mass balance model.
Okay. Another question, does cigarette smoking affect PFAS elimination? You mentioned alcohol, diet, and cigarette smoking is another important toxicologic exposure.
Yeah. PFAS are not really metabolized by any ZIP enzymes, not the ones that we tested here, because there's a difference between terminal PFAS that are highly ionogenic and are basically cannot be processed by the body, and that's why they stick around for years. But there are PFAS precursors and that's one of the projects that we have running right now that are metabolized by ZIP enzymes. And cigarette smoke can induce certain ZIP enzymes, so it would be very interesting to look at the interaction between these kind of factors. And essentially, yeah, I mean, we just submitted a paper that looked at how PFAS, because they are also inhibitors for certain ZIP enzymes, may affect how well your body metabolizes the drugs that you're taking. So there's this duality of thinking about environmental chemicals and drugs, that the one can affect the other, but the other can affect the one as well, and lead to either like loss of therapeutic efficacy for certain drugs if you have high levels of PFAS or other contaminants in your body. So I hope that the work that we are doing will incentivize measuring environmental contaminants in future clinical trials and account for those as covariates when assessing the therapeutic effect, efficacy, or safety, toxicological effects of new medications.
Very interesting. And is there a role for AI methodology in these complicated experiments that you're describing?
Yeah, I mean, people ask me if I use a lot of AI for developing my models. I don't, and I don't think I want to use AI, because now we have a very well-defined model and we have everything very well under control. So I'm kind of hesitant to, use AI and have a black box again, because we use these models to actually look at various specific mechanisms like BCRP for breast milk accumulation. So if we now involve AI or machine learning, then we would get away from having a very specific model to we are working with a black box that is calibrated in vivo. It is definitely an option, but as long as we can derive all of these parameters and have them very highly parameterized models, I don't think it's necessary, actually.
Got it. Wow, very good. Well, let's see. I'm just looking here. I don't see any other questions in the chat. So we'll close now, and with thanks to both of our speakers. We really, really appreciate your taking the time and effort. These recordings will be available on the Advanced CTR YouTube channel. And interestingly, your mentor, Angela Schlitt, is going to be the next speaker in this seminar series. She'll be speaking on Thursday, March 12th. So,
Oh yeah, I think I was supposed to show the last slide, which I forgot, which has her name on it.
oh, okay. Well, we got it. Anyway, thank you once again, and enjoy the rest of your days. Bye-bye.
Thank you. Bye.